My work primarily hinges around digital medicine, but there's been a lot of controversy, a lot of excitement, and a lot of confusion around this particular topic. The first question that we routinely get asked is really, what is digital medicine? We see it everywhere, but there's very little definition on what it's actually about. We hear terms like mHealth, we hear terms like mobile health, telemedicine, e-medicine, but there seems to be very little clarity as to what it actually means. For me, digital medicine is just about leveraging different sources of information for healthcare. Mostly it's around capturing information that we can already use in day-to-day healthcare, but about doing it in interesting and novel ways, about piecing it together in really exciting ways, but also using the collection of those data streams to really provide us pictures of medicine and ways of practicing medicine that we haven't been able to participate in before. The analogy that I always like to make, and I know Dr. Kamada already likes to make as well, is around this concept of aviation. I wanted to be a pilot when I was starting off my career, and then I was a doctor, and my brother said, you've got to make a decision. You can either fly the plane or treat the patient. You can't do both. So I've spent most of my life trying to combine both of those together. But collectively, when you think about aviation, this is how you navigate in aviation. You use a standard paper map, which is updated about every 6 months. You use an aviation directory, which lists all the services and facilities, your runway lengths, etc. And interestingly enough, this is actually a flight computer. And you can navigate and fly safely with all these pieces of information. So these are effectively historical remnants, but are used on a day-to-day basis. And this is, I think, akin to a lot of the way we capture information in medicine. You can still do it absolutely fine, but there are ways now we can do things that are leveraged by technology pieces that actually provide us ways to do it in really interesting ways. And the aviation equivalent is, this is ForeFlight, an app. So it's using all the same information, and it basically overlays your GPS position. It shows where all the weather cells and storms, it gives all the information pieces, all the same information, but can also provide additional layers like 3D synthetic vision so you can see in the clouds. So this is really, I think, a great kind of parallel insofar as looking at the same data pieces that we would historically be used to, and putting them in a really usable format, and also augmenting it so that we can see things that we haven't been able to see before. The issue with digital medicine is there have been somewhat false starts, but also a lot of hype and a lot of criticism, and deservedly so. Withings, I think, was one of the kind of the forefront product manufacturers in digital medicine, and has made some great stuff. But this is their thermometer. And for only $100, you can get a thermometer that does 4,000 measurements in 2 seconds using various different sensor suites and technologies. And I think that that's a little bit crazy. I'm not sure if any of you remember the way we would normally take temperature, but I think it speaks to the idea that this is about kind of solving problems that don't need to be solved. And we see this all the time at Scripps, whereby people will come to us with these amazing technologies and solutions to problems that don't even exist. And we need to be very careful about how we leverage these technology pieces to address the appropriate clinical unmet needs. And this is an example of one of them that doesn't actually apply here. One of my other favorite examples of digital medicine hype is the Happy Fork. And the Happy Fork, if you think about it, addresses obesity, which is a big problem. It addresses overeating, which is a big problem. So something in the middle should clearly be very useful. And the Happy Fork basically vibrates on a predetermined frequency so that you don't put your food into your face too fast. Now, I know that I just changed the frequency and eat away to my heart's content, but I think this is just an example of, again, a technology piece that doesn't serve a place or purpose. And just because you can invent a vibrating fork that connects to your phone doesn't make it in any way useful. Now, this, I think, is actually my second favorite example. My most favorite example was just released recently, actually, to put a balance to the Happy Fork, this is the Gyno Fork, which I think is probably one of the best examples. And this is an anti-servo fork, which basically neutralizes the frequency of oscillations of a tremor so that you can eat properly. So again, this is incredible. So this is something that's super useful and super practical. But when you compare it to the Happy Fork, it's a totally different animal. This is my favorite. This is the Nokia Hair Coach, for all those men in the audience with long hair. And basically, this is a hair coach that's fitted with a microphone that listens for dryness. Sensors that analyze brushing and hair quality. And if ever there was a useless technology that could be introduced into maybe not health but cosmetic technology, it really doesn't apply. So I think part of this has been driven by the fact that the regulation groups for medical devices in the digital medicine space have been quite lax, because the turnaround time and the cycle time is quite quick, and it's hard to over-regulate, and we want to get these technology pieces to market. And we want to have them in the hands of physicians, in the hands of patients. But I think most people's understanding and perception of digital medicine would probably be something along the lines of these three technology pieces. And I'm sure everybody in the audience at some stage or another has bought one of these, worn it for a period of time, and then gotten rid of it. And the criticism for digital medicine is born around sometimes these particular technologies, which have some utility, but just not for all. They can be interesting to change a habit so that you can have that as a sustainable piece. But as the forefront technology, we can see that this billion-dollar market in terms of wrist-worn wearables hasn't borne out the promise that it was originally made. Fitbit's stock prices dropped about 70% recently. Jawbone's CFO has recently left. And the Nike Fuel Band, I think, is the one to rule them all, and then the one to fall. So there's been a lot of kind of false sparks in this particular area. And again, several of these technology pieces have all ended up in our bedside lockers with empty batteries and given to our nieces and nephews to play with effectively. So not only have they been criticized, there's also some pushback insofar as that these devices are possibly even doing harm in terms of how we utilize the information from these devices to make our healthcare decisions. This is David Stewart, and there were several articles in the middle of 2016 saying, "Is your Fitbit making you fat?" And David Stewart used this device and put on a substantial amount of weight rather than lost weight. And I think it's to do with how we utilize the information and where we leverage its importance. The activity trackers are based around maybe an over-reliance on activity for weight loss rather than diet. And this has actually been studied. And you can see here in the IDEA trial published in JAMA last year that if you look at a standard intervention group and a wearable group, both groups did lose weight, but the wearable group, you can see, lost less weight. And this is what really prompted the "Is your Fitbit making you fat?" movement. So again, I think the Fitbits, they're interesting concepts, they're useful tools, but they need to be viewed appropriately and how we actually integrate them into healthcare. When you put all of these things together, there has been substantial pushback, and mostly rightly so, from a lot of healthcare providers, insofar as almost calling it digital snake oil. And one of the main critics of it has been the CEO of the AMA, who last year effectively coined this term digital snake oil. And as he points out here, it's not really a criticism of one particular device, one particular tool. It's really a criticism of the lack of regulation, the lack of oversight, the lack of applying to clinical need, and really kind of an attitude of the entire market. So I think this speaks largely to a lot of the hype that's existed, the early to market technology pieces that really haven't served their clinical needs, but there is still so much potential in terms of how this can actually be done. Because no matter what tool you use, even though it can be incredibly useful, it can be used on itself and it can destroy itself. So I would say one of the areas I think that has done particularly well and has managed to deploy digital medicine in a very validated, evidence-based practice and methodology has been in the field of cardiology. And that's my own field. And it's something that I use on a day-to-day basis in clinical practice. We see our colleagues use it, and we see it integrated into clinical care pathways to really change and alter how we practice medicine. So I think I'd like to use cardiology as one of the lenses to view digital medicine so that we can actually see the story of the hype, the hope, and the history of some of these technology pieces. When we look at ECG as kind of our main stalwart of cardiology diagnostics, I think we tend to look at this quite fondly in terms of the first ECG machines back in the early 1900s with Eindhoven. But we have to realize that when these were actually taken, the information was transmitted about 1.5 kilometers away and was remotely read. So telemedicine actually existed back in 1905 with the first ECGs. I also look at this and dread being the intern on call, being asked to do an ECG on a particular patient. I can imagine it would be a rather challenging scenario. But it really wasn't until the mid-1900s that there was a need to perform remote diagnostics and remote ECG monitoring on patients. And the patients and the need were the early astronauts. This is Alan Shepard in 1965, getting ready for the Gemini missions, going to space in what can only be described as a portaloo. But they needed to actually analyze and monitor these people in the zero gravity environment because they didn't really understand what would happen to these people. There was fears like that their eyeballs would lift off the base of their sockets of their eyes and cause a refractive change, so they would be unable to see any of the instruments. So they needed to develop the technologies to actually enable patient monitoring. And what's, I think, somewhat frightening is that the technology pieces that were developed as cutting-edge telemetry pieces in the 1960s don't look that dissimilar to what we use on a day-to-day practice in our cardiology care today. This doesn't look that different from a regular Holter or telemetry system that would use in any intensive care unit or critical care environment. And this is my favorite telemetry piece of all time. And for all you conspiracy theorists out there, just the leads fell off for all the people who look dead. And I think it's fairly understandable that Neil Armstrong's heart rate when he's just about to run out of fuel landing on the moon is acceptably high. But I think it gave a picture of things that we would never have been able to see. But it's because of this. It's because of all this innovation, because of this particular need, gave us our modern day intensive care unit, gave us the facilities and abilities to be able to monitor people in critical care environments during operative procedures, in the CCU, ICU, whatever. So I think it is that kind of loop insofar as the developments for the space technology piece that gave us all the technology pieces for terrestrial-based activities. Fast forward 40 years, there's no development to this because nothing happened to the astronauts really anyway, but now you have lots of regular Joes, just like me and everybody else, who want to go into space. The problem is what happens to these people who are not supreme athletes, and how do you monitor them? The reality is there actually hasn't been the same pace of technology and development, so we don't have the abilities to monitor these people in the zero-gravity environments like with zero-G and AliveCore, etc. And this is some of the work that actually Dr. Kamada Reddy and I had done some years back using, this is the Sotera Wireless Visi Mobile. And it's basically a mobile intensive care unit that does all the telemetry monitoring that you would imagine, but it's effectively worn on your wrist and has a thumb-based continuous non-invasive blood pressure measurement. And what we had done was with a NASA-supported grant that Dr. Kamada Reddy was really pioneered, we got to test and validate this for use in the zero-gravity environment, for use for near-Earth activities, as they like to describe it, on my favorite airplane ever, called G-Force One. Now, this was a flight out of Houston with the NASA facility there where we were actually validating this in the zero-gravity environment. And we like to say validating it, but we were actually just having lots of fun floating around in the zero-gravity experience and simulating what medical emergencies would look like and how things basically just float away if they're not attached. So this is a super important piece in terms of the technology readiness platform for NASA. Now, it's also a really cool place because you get to go to the Neutral Buoyancy Lab, which is the biggest swimming pool in the world, which they have a mock-up of the International Space Station. And most of you will recognize it from the underwater scenes in the movie Armageddon. When he says, "Trust me, Harry, I know what I'm doing," but he doesn't. When we look at blood pressure in terms of where this has come to and where it has come from, this is Reverend McHale doing the first examination and investigation of blood pressure. And this poor horse, I would imagine the measurements he was getting were declining rapidly when there was a copper tube stuck into his carotid artery. But when you look at how it's evolved and changed over time, it really hasn't changed a huge amount since these early blood pressure devices. And when we look at, again, the digital medicine pieces of blood pressure monitoring, these are things that have been around for several years. The Withings BP cuff that wirelessly connects to your phone, and the Omron wrist-worn monitor. Now, you can say that these are fairly simple technologies that we've had for several years, but because of the prevalence of hypertension and its often inadequate treatment, it's simple changes like this that can make huge societal population-based impacts. And we routinely have patients email us their longitudinal list of their blood pressure changes. So this is a whole new way to actually visualize patient information when they're not in the office. But when you start to then scale things up in terms of the technology pieces that are available and more advanced hemodynamic monitoring, this is Swan Gant's catheter, and Swan was from Sligo. His father was actually a doctor to W.B. Yeats. And he had this idea watching sailboats in Santa Monica. But again, it's floating a pulmonary artery catheter with a significant amount of risk, not a huge amount, but a small amount of risk. And this can be replaced by, this is a technology piece called the COVA, the 2-sense COVA, which monitors patients, particularly with heart failure, looking at thoracic impedance, heart rate variability, cardiac output, and stroke volume. And the idea is that you would use these to monitor heart failure patients or those who needed advanced cardiac monitoring, either remotely, non-invasively, and in a safe fashion to predict decompensation. So this is, again, I think an illustration of what we can get from an advanced cardiovascular monitoring. From an ECG perspective, this is one of the examples of, I think, early ECG pacing. This is Catherine Serafina, who's a Prussian lady who had a radical Halsted mastectomy where you could visualize the anterior portion of her heart. And you can see they're toying with it. I wouldn't imagine she lived particularly long with their prodding of her heart. But this led to earlier self-starter kits, which I wouldn't imagine sold very well during the Vietnam War, an early idea of your ICD. And this, I think, speaks to, it's all kind of funny to look back at this, but now we have actually technology pieces whereby you can implant pacing technology without any leads in the size of a euro from either St. Jude's or Medtronic's in someone's RV and leave it there for 10 to 15 years. So I think, to see this iteration is just incredible in terms of the miniaturization of technology pieces. But again, when we look at Alan Shepard and his Holter monitor, and this is first ever Holter monitor which weighed only 38 kilograms, we can see how the technology pieces have evolved. But today, what we use on a regular basis instead of Holter monitors, we use the iRhythm patch, which is a single lead ECG, and the Vital Connect for vital sign measurements. So this is a huge leap forward in terms of how long you can monitor your patient for and for what activities they can do. The Vital Connect, I think, is an interesting piece which we'll talk about, but this is a comparative study Dr. Kamada Reddy and I did some years back comparing the two, and understandably, the iRhythm patch was superior in terms of detecting arrhythmia events, predominantly because of its longer wear time. The Vital Connect has some interesting uses. This is Steve Steinhubel, the Director of Digital Medicine at Scripps Translational in Sierra Leone. And one of the big issues during the Ebola crisis was that you had to expose healthcare workers to take measurements from patients. But when they did that, it put them at risk of being contaminated. So this gave healthcare workers an opportunity to monitor patients remotely. The AliveCore, I think, really has been one of the stalwarts of remote cardiac monitoring. This is the first and second generation, and also how you can perform ECG using an AliveCore watch, and that will do remote readover. And even the most recent update is the 6-lead ECG, which looks at much more information that you can get. You're seeing this change into flexible patch technologies, and these have been around for quite a while in terms of their ability to measure EMG, ECG, etc. But it's really the battery power that has made these move forward. The technology to locally do this has been around for a while, but the battery power technology so that patients can use it remotely is the thing that has changed somewhat. But you can even do point-of-care sweat testing analysis and look at a whole variety of parameters and put them in contextual situations, which we really haven't been able to do before. My other favorite is the idea of auscultation in cardiology. This is René Laniak in the early 1800s examining a TB patient, listening for the classic pericardial crunch of pericardial calcification. But there was a lot of issues around physicians examining patients with illnesses and having their ears so close, and there was a lot of the female community who weren't too excited about how physicians would examine them. during various different cases. So effectively, it comes down to you have a rubber diaphragm, a tube, and someone listening at the other end. But you're listening for a proxy sound. All you're trying to do is infer something from a physiological or anatomical basis based on proxy information, which is sound. And the iterations of the stethoscope have changed quite a lot. Arthur Leard in the early 1900s was responsible for the biurnal stethoscope. But it hasn't changed a huge amount, and we still use proxy sound information. And this has been one of the pushes from Dr. Topol and I, looking at the art of medicine to truly look inside, and the history of the stethoscope, which is 200 years old last year. And stethos, meaning chest, and scopen is to look inside, but it does nothing of the sort. It listens. It doesn't look inside. And really, if you look at Dr. Topol's piece on this, is that he hasn't used a stethoscope in, now it's about, 7 years or more as a cardiologist. And that's really because often there's an inappropriate utilization of technology pieces that are very expensive, which can be replaced with point-of-care ultrasound. This is the GE vScan, which is invented in 2009, and this is its more recent iteration. And this is the Philips Lumify, which basically is an attachment to your phone. You can see here us demonstrating the 200-year evolution from stethoscope to point-of-care ultrasound to attachment to your phone. And we use this in clinic on every patient we see. I sometimes sneak in my stethoscope, but he doesn't like it. But there's loads of different iterations of this, and it's something we're seeing an explosion of, and we're seeing medical students from day one being taught with this. One of the other things that I think we're really trying to push is the use of genomics. I think, again, another area that's got off to a false start. But this is an integration and a collaboration between 23andMe and ourselves at Scripps, where basically if you do your 23andMe, we will give you your live, continually updated cardiovascular risk scores and the likelihoods of you benefiting from statin therapy. So this is just an example of some of the work that we're doing. You can see this is a paper we hope to publish in the New England Journal of Medicine in the coming months, looking at building prospective risk scores based on several different SNPs for the development of atrial fibrillation. And it's about piecing all of these things together. It's not that this is absolutely deterministic, but it's about having this in your armamentarium of what you use to see your patients and how to determine risk. I think in terms of cardiology, we have a lot of exercise technology pieces. The Fitbits were one example, but we're seeing much more refined technology pieces. This is Tune. I think it's a Scandinavian starter campaign that basically gives you insole analysis of your heel striking time, heel contact times, ground contact times, and will actually provide live feedback coaching when you run. The other ideas of wearables in terms of true wearables, the Athos shirts, you can see, which is live EMG during exercise, but you can see how this could potentially be redeployed for use in healthcare settings. This is my favorite view, and that is an empty cath lab table. As a cardiologist, that might sound strange, but historically in cardiology, we have been used to identifying dead myocardium when you actually have a plaque that could potentially be rupturing or losing cells for hours, days, or weeks before you have an MI. But once the horse has bolted and you develop symptoms, it's too late. So our theory was that if you could detect these cells that were rupturing off the actual plaque for periods of time beforehand, that you would be able to detect people who are at highest risk of developing a cardiovascular event. And what those cells are what are called circulating endothelial cells. Now the problem is if a patient is asymptomatic, how are you going to detect these? And you can see that we have done lots of validation studies in terms of the numbers are higher in patients who have acute coronary syndromes. Morphologically, they look different. So we built up this really kind of multi-layered signature, including a genomic signature, which the plan is, and we work with Axel Shearer in Caltech, is to use this digital signature to match it to an implantable nanosensor technology piece, which is currently in vivo testing, and really implant it in your arm to detect and looking for this abnormal signal. And we call it the text message that you never want to get, insofar as that you are at high risk. You can see this being developed for a whole variety of conditions. We call this the molecular stethoscope for early detection of cancers. And also, you can look at for early stage, depending on the signature that you use, for early stage rejection of solid organ transplants, for early onset of diabetes or heart failure. Now, we even use it for after death. This is a study that, that the group at Scripps have done in terms of looking at etiologies of heart events as sudden cardiac death phases. And the idea is that you close the loop. You define the signature, that you actually send a sensor piece to your phone or to a healthcare provider, and that you then begin a therapy almost immediately. And you have a closed loop system. And you have this for a variety of pieces in terms of sutures. You have it for any implantable devices, and this is around tumors to look at actual tumor response rates, and potentially even any of the other implantable pieces and technologies that we use. So the idea is that we would get these inbound streams. Now, I do not think we have the infrastructure yet to deal with these inbound streams of information in our current healthcare architecture, but other groups have managed to make this work. Rolls-Royce are the lead groups for telemetry systems, and they have it for all their engines in maritime and in aviation. And they're continuously monitoring engine performance around the world. And often when a pilot will land, they will know something about the aircraft before the pilot does. And I think this is one of the mechanisms or outlines that we can use for monitoring our patients in healthcare, that we would have broad live-scale telemetry systems. You can see here, this was one of the examples where the Rolls-Royce crew knew more about the Malaysian Airlines crash than most of the Malaysian Airlines or many of the actual the radar systems. And this shows also the interesting ways that this technology piece can fail and can expose things that maybe we hadn't originally intended. One of our huge obstacles is the idea of healthcare breaches and data breaches within the healthcare arena, which has huge potential for personal liability. But I think we have a long way to go, and if the CIA can't even protect their information, what hope do we have? So I think this is super important because we're starting to do research on a population scale. This is Apple's research kit, but also this is the Precision Medicine Initiative. And this is a $216 million grant that Scripps was partly awarded for recruiting 1 million people and building a whole biometric signature for these people to advance our understanding of a variety of different disease states so that individual metrics can provide collective or collaborative learning. So I think we've covered some of the history, where this technology has come from and where it's going. We've covered some of the hype in terms of where the bad side of this has been and what we need to cull, and some of the hope in terms of what we can potentially expect in the future and what we're aiming towards. So I think if anyone wants to learn anything more about this, we are writing a piece in The Lancet every several weeks. There's one already on rebooting blood pressure towards a smart medical home, and I'm bringing out a piece in the next couple of weeks on digitizing the mind using various digital medicine technologies. And if anyone wants to look at submitting research on this, this is the Nature arm of the Nature Publishing Group on digital medicine, which we have the editorship for. And I think it's going to be an exciting time in digital medicine, as long as we avoid the hype and we push towards the better future that we have advertised. Thank you.